Hello, everyone. And good morning, good afternoon, or good evening to you, wherever you are in the world. We want to thank you for participating in this webinar today. And I want to thank our co-hosts, the High Impact Practices Group and the IBP Initiative, along with FP 2020, for coming together in collaboration so that we can discuss together family planning in humanitarian settings, and in particular, the work of many of the people on this call to craft together a strategic planning guide for family planning and humanitarian response, and to look at this now within the context of the COVID-19 global pandemic. So I'm Beth Schlachter, I'm Executive Director of FP 2020, and again, we're very glad to have you join us here today. Our webinar is going to be comprised of a few different sections. We have a number of speakers who I will be introducing one by one. I'm going to start with the presentation itself on the strategic planning guide, and then we'll have time for your questions. We will be recording today's webinar, and we'll be recording all of the questions as well. So if we don't get a chance to answer your specific questions, we will be sharing them with each of the presenters so that they can get back to you directly with an answer if you ask something of someone in particular. And we'll also then be sharing answers to questions online virtually after this as well in the coming days. So do reach out with any question or comment that you have so that we can keep this conversation going together as a global community. The presenters and I were just talking before we got started about how this moment in time, we're so grateful to have such a connected community and the tools and the software available to, I hope, all of us, so that we can continue conversations together, even as we're working from quarantine, from home, or in distant and difficult situations. So again, before we begin, just note that you can submit your questions anytime. And again, we'll do a Q&A after the presentations. You can also download all of the handouts that people will refer to today from the toolbar that you can see visible here. And I encourage you in particular to go ahead and take a look at the strategic planning guide, because we'll be referring to that throughout this presentation today. And please also remember that you can visit the High Impact Practices website at any time for a full range of the HIPs. They do help guide all of our work, so remember that's always a resource for you, and they're being constantly worked on and updated, and new either high impact practices or these strategic guides are uploaded on a regular basis. So now let's go into discussing what high impact practices are. So they're a set of evidence-based family planning practices that are vetted by experts against specific criteria, and they're documented in an easy-to-use format. HIPs help programs and programmers to focus resources for greatest impact. And again, the high impact practices briefs and the strategic planning guides can be used for advocacy, strategic planning, program design, looking at research gaps, and to inform policies and guidelines. And finally, and importantly, they're there to help support your implementation and to ensure that we're focusing our efforts on those practices that are proven and effective. Next slide. This HIP, the Strategic Planning Guide, is dedicated to our beloved friend and colleague, Jennifer Schlecht. Jen had devoted her entire career to ensuring that women and girls in crisis situations have access to the best medical care possible during family planning and other reproductive health care. Jen was the driving force behind this strategic planning guide and was instrumental in advancing family planning and sexual and reproductive health preparedness work to help face the global crisis of increasing humanitarian disasters and ever more people living as refugees and as internally displaced people. She had a vision to expand shared learning and guidance for preparedness, and thus to strengthen sexual and reproductive health response and to help meet family planning goals. We miss her dearly, but we're so grateful that we're continuing to build on her work and her vision. And this strategic planning guide and today's webinar are dedicated to Jen. Next slide, please. The map you're seeing now indicates, as of 2018, new displacement by conflict and disasters, where orange is showing conflicts and blue is showing disasters. All countries are vulnerable to emergencies, and this graphic shows that emergencies can be an equal opportunity invader, and in fact, we're all certainly living that now with COVID-19. But please remember that this is a slide from 2018 and it does not represent the impact of the current global pandemic. So we're going to spend a minute on this because it'll be important to understand what we're seeing, to think about preparedness in a global context. And again, COVID-19 really, I think, has opened the eyes of the world that these crises can strike at any time. And if you're not prepared, it's going to be harder to respond, it's going to be more costly, it's going to potentially cost more lives and resources, and it will be more difficult to build back to where you were, much less to keep those development gains going forward that everybody is working so hard together to achieve. So what we're seeing in this slide is that there are 28 million new displacements associated with conflict and disasters across 148 countries and territories in 2018 alone. Unresolved conflicts, which again you see in orange, and a rise in communal violence were responsible for most of the over 10 million new displacements associated with conflicts and violence in 2018. Weather-related hazards, particularly storms, accounted for the majority of the new displacements associated with disasters, which you see in blue. And this triggered a little over 17 million displacements in 2018. Sub-Saharan Africa and the Middle East were disproportionately affected by displacement associated with conflict and violence in 2018, and new waves were also recorded in South Asia. Displacement associated with disasters mainly affected East Asia and the Pacific and South Asia, both regions with high levels of population exposure and vulnerability to hazards. A total of 41.3 million people were estimated to be living in internal displacement as a result of conflict and violence as of the end of 2018. And at that point, that was the highest figure ever recorded, and we all know that that was exceeded in 2019. Next slide. So the document that we're going to look at today leads us to national and subnational decision makers through a strategic process to identify actions that improve family planning access in places at risk of experiencing and recovering from crisis events. Actions put forward here represent the learning across countries and agencies that have engaged in emergency preparedness, response, and recovery, and are informed by experts who have worked across these three phases. So let's look at these three phases. Next slide, please. Ensuring continuous access to family planning for populations experiencing a humanitarian crisis is needed, demanded, and importantly, it's feasible. And here I'd like to quote our friend Jen, who said that women who are displaced have the same reproductive health needs as other women, if not more. I think there's an increased acceptance and understanding that crises are not something that happen to other people. This understanding opens so many more opportunities for all of us. It was that approach that Jen had, that working together presented opportunities to do more together and to meet the needs of those who were in greatest need, that has really driven our partnership and drove the creation of this strategic planning guide. Because we know that disruption in family planning services can be minimized through preparedness actions, crisis response, and coordinated transition back to routine services. So let's look at each one of these individually now. Next slide. Preparedness actions improve the timeliness and quality of a response and increase efficiency during a crisis event. Governments that invest in conducting preparedness activities can realize significant cost savings, reducing the overall strain on overburdened local and international humanitarian systems and helping to ensure that development gains are not lost when crisis strikes. So if you had a chance to download the strategic planning guide, you'll see that each of these actions are broken out in greater detail in the guide. Let's look next at crisis response. Next slide. Crisis response activates the humanitarian cluster system, including a health cluster and sexual and reproductive health subcluster, to ensure coordination within each sector across both existing partners and new partners that enter to provide relief. The reproductive health crisis response, including family planning, is organized around the minimum initial service package, known as the MISP, for reproductive health, which was updated in 2018 and repositioned family planning under the heading of Preventing Unintended Pregnancies as one of 4 main clinical and life-saving services of the MISP. Next slide. The final phase is coordinated transition to routine family planning systems, which should be an early consideration and response. Such transition should occur as soon as possible and often can begin 3 to 6 months after a crisis event occurs. The transition should be done with minimal disruption to service delivery. So as you're providing services, you're already transitioning and planning back to regular system of development. So finally, for me, the last slide I want to share with you is that FP 2020 is continuing to partner with humanitarian organizations, as evidenced by our forthcoming publication, Ready to Save Lives, a preparedness toolkit for sexual and reproductive health in emergencies. The toolkit, developed in partnership between FP 2020, IPPF, JSI, the Women's Refugee Commission, UNFPA, and the IWAG, is a set of materials to support country-level actors to initiate and implement sexual and reproductive health preparedness actions in order to ensure SRH services are continued during an emergency response. The purpose of the toolkit is to share steps, tools, recommendations, and learnings with country-level actors to act as a starting point to undertake SRH preparedness work and inspire more documentation and shared learning globally. This toolkit aims to help countries, in the best case scenario, to be able to maintain a continuity of comprehensive SRH services in an emergency and in a more widespread event, prepare to provide the minimum SRH services needed until the situation is stabilized. The work for this toolkit began in 2019, and again, this is a vision of Jen's, and she led this early work, secured the grant, and got us all working on this together. But we're finally going to be able to wrap this up later this month, and we hope to launch it in early July. And we recognize that the work now is being done within the context of the COVID-19 outbreak. So this toolkit is meant to be useful for all emergency preparedness, even beyond our current urgent and global preparedness response efforts for the pandemic. But we've been able to include some of the relevant learnings related to COVID-19 as well. And you'll be able to select links to COVID-19 and SRH response through the toolkit and through link to other resources. But we want to remind that the toolkit is importantly useful for any emergency. So thank you very much. And now I'd like to introduce our first speaker, who is Lily Jacoby with the Women's Refugee Commission. So Lily, over to you.
Thanks very much for that introduction, and many thanks to FP 2020 and the IPP Network for the opportunity to participate today. We look forward to providing some context for this webinar on the Strategic Planning Guide, and I'll be presenting a global snapshot of contraceptive services across crisis-affected settings. We would like to note that this presentation details essential key findings from a global landscaping study, and the full report will be published in late summer. Slide. Access to contraception is a human right and saves lives in humanitarian settings. The 2018 revision of the MISP for sexual and reproductive health includes the priority objective of preventing unintended pregnancy for the first time. However, we know that access to contraception continues to be a gap in humanitarian settings. Accordingly, with complementary funding from 2 donors, the Women's Refugee Commission embarked on a multi-methods landscaping assessment to improve knowledge on the state of contraceptive services and assess progress and challenges to the successful implementation of contraceptive service delivery in humanitarian settings, and to identify key recommendations to accelerate access to contraception for crisis-affected populations across the humanitarian development nexus. The assessment was mixed methods and includes a literature review, a global coverage survey of implementing partners, key informant interviews, and case studies in 3 humanitarian settings. Slide. The first component of the landscaping assessment, the literature review, assessed the publicly available evidence base on contraceptive service delivery in humanitarian settings. The evidence consistently demonstrates that across diverse settings and populations, there is high demand for contraception, and women will use contraceptive services when they're made available. However, there are gaps in the availability of contraceptive services, including adequate method availability. Challenges with supplies and supply chain management, including stockouts, and data collection persist across contexts, and barriers remain greatest for adolescents and marginalized populations. The evidence on specific interventions is limited. However, there is programmatic evidence supporting multi-pronged contraceptive services programs designed to improve method mix, provider capacity, commodity availability and security, and monitoring and evaluation. There is also evidence for program models that incorporate proven high-impact practices in development settings, including community-based service delivery via mobile health units and community health workers, and the provision of contraception and post-abortion care. There are also 2 publications supporting subsidies and voucher programs. Voucher programs are also listed as enhancing factors for high-impact practices that support access to contraception in development contexts. Slide. For the second component of the landscaping assessment, we conducted a global coverage survey concluding data collection in spring of 2019, notably prior to the COVID-19 pandemic, to capture a snapshot of the state of contraceptive service delivery across humanitarian settings. 7 international NGOs, 12 national or regional NGOs, and 1 UN agency participated, representing 84 programs across 42 countries and territories. Slide. This graph presents the percentage of country programs providing different contraceptive methods in all or some supported service delivery points in the blue bars. The red bars show the percentage of those country programs providing a method in all or some service delivery points that reported a stockout in the 3 months preceding survey submission. Oral contraceptive pills and injectables were available in more than 90% of programs. IUDs and implants were somewhat less available than these short-acting methods, but still widely available in 85% and 75% of programs, respectively. Emergency contraceptives were available in 81% of programs, while only 66% of country programs reported providing condoms in all or some supported service delivery points. Stockouts appeared to pose challenges across programs and methods, ranging from 23% of country programs reporting stockouts of OCPs to 13% for implants and injectables. However, it is important to note that many submissions indicated that they did not know about the occurrence of stockouts, ranging from 7% for condoms to 21% for IUDs and 25% for EC. It is therefore possible that the occurrence of stockouts was higher than is reflected in the data collected. Slide. This graph shows the percentage of country programs providing IUDs, the blue bar, and implants, the red bar, in all or some supported service delivery points by region. Across these 3 regions, the provision of IUDs ranged from 62% of programs in East and South Asia and the Pacific to 95% in Sub-Saharan Africa. The provision of implants ranged from 39% of programs in the Middle East and North Africa to 95% in Sub-Saharan Africa. All 3 programs in Latin America and the Caribbean provided both IUDs and implants, but given the small sample size for this region, we did not include it in this graph. Slide. This graph shows the percentage of country programs providing injectables in the blue bar, oral contraceptive pills, the red bar, condoms, the gray bar, and emergency contraceptives, the green bar, in all or some supported service delivery points by region. Pills and injectables were widely available across all 3 regions. The provision of condoms ranged from 51% of programs in sub-Saharan Africa to 76% in East and South Asia and the Pacific. The provision of emergency contraceptives ranged from 67% of programs in East and South Asia and the Pacific to 89% of programs in sub-Saharan Africa. All 3 programs in Latin America and the Caribbean provided all of these short-acting methods. Slide. For the key informant interviews, we wanted to contribute to filling gaps in our understanding of what works to support contraceptive programming in transition periods across the preparedness to relief to recovery continuum, including challenges and strategies to successfully scale and transition programs as situations stabilize or evolve, and to improve collaboration across the humanitarian development nexus. The strategic planning guide is another really promising advancement for the field in this respect, and notably calls for participation of and coordination between diverse stakeholders across the preparedness to relief to recovery continuum. The key informant interviews focused on contraceptives programming in these transition periods and across the humanitarian development nexus. We conducted 14 interviews with 17 key informants, including field and headquarters staff, and including respondents from development organizations and development teams at dual function organizations. Slide. Over the course of interviews, a number of themes emerged around the factors that affect the processes and outcomes of transitions. First, respondents emphasized that contextual factors, namely the existing strength, capacities, and structures in country, significantly impact transitions. Respondents cited particular challenges in areas with cyclical and protracted violence, where there may be institutional vacuums. Multiple respondents speaking about emergencies in different contexts cited the existence of a coordination mechanism as being important for a successful transition. One of the most common themes that emerged when discussing coordination across the nexus was a lack of cross-sectoral communication. Interestingly, these themes also emerged within dual function organizations. Many respondents from these organizations reported that their organization did not have a formal protocol for determining if, when, or how to shift responsibility for program management in transitioning settings. Many respondents reported that humanitarian and development teams within their organizations tended to be siloed, and that this impeded the efficacy of their work. These silos were reportedly compounded by vertical funding streams. Funding was cited in all key informant interviews as a determining factor in the success of a program to effectively transition across different points in the humanitarian response cycle. Many respondents described frustrations and challenges posed by the siloed nature of funding streams, including a lack of dedicated funding for transitional or fragile settings. All respondents cited siloed funding streams as an obstacle to collaboration across the humanitarian development nexus. Sustained long-term funding or dedicated funding for the transition phase was instrumental to successful program transitions in diverse settings. Conversely, multiple respondents reported programming being forced to close as a result of a loss in funding. Development respondents also specifically mentioned lower risk tolerance among donors who fund more traditional development projects. Slide. We also explored organizations' strategies to manage transitions over the course of an emergency response cycle. The most widely cited strategy for transitioning programs successfully was conducting capacity building and systems strengthening activities over the course of a program. This included providing clinical training and supervision to providers and supply chain strengthening. This builds local ownership and ensures that programs can be sustained after the organization is no longer operating and responsibility has shifted entirely back to local actors and authorities. When queried about key measures to improve coordination across the nexus, respondents were nearly unanimous in citing the importance of strong formal coordination mechanisms and in engaging development partners in these mechanisms, even as observers from the outset of a response to share information, build partnerships and capacity, and set the stage for future transitions. Finally, both development and humanitarian respondents expressed the need for building the evidence base on program models that have successfully engaged humanitarian and development actors in coordinated programs, including information on challenges and strategies for success. Slide. Finally, we conducted case studies in Cox's Bazar, Bangladesh, Maiduguri, Borno State, Nigeria, and in Cyclone Idai affected areas of Mozambique, to document the work that stakeholders, including governments, are undertaking to provide contraceptive services to affected populations. In all three settings, WRC researchers conducted key informant interviews with key government, UN, and partner organizations, facility assessments, including the administration of knowledge and attitudes questionnaires to providers, and focus group discussions with affected communities. We've pulled some key findings out from across settings. Slide. First, across all settings, short-acting methods were more widely available and accessible as compared to LARCs and to EC. Also across all settings, adolescents faced the greatest barriers to accessing contraceptive services. Barriers included misconceptions about methods, particularly LARCs, and negative attitudes towards the use of contraceptives among community members. Religion posed a particular barrier in Cox's Bazar and in Borno State, but was cited less frequently in Mozambique. Partner opposition was cited across settings. Stockouts compromised the availability and accessibility of contraceptive methods in Borno State and Mozambique. Across settings, there were systems in place to collect and report data. However, quality and consistency of data collection and reporting varied across settings and appear to pose a particular challenge in Borno State, Nigeria. Finally, funding, leadership, and coordination contributed to the availability and accessibility of contraceptive supplies and services across settings. The availability of funding and the strength of the coordination varied across settings, but it was clear that it played a key role in distributing commodities and avoiding duplication of activities between partners. Slide. Based on key findings from across the landscaping assessment, we have identified the need to meet the clear demand for contraception in humanitarian settings, improve data collection, and build the evidence base on effective contraceptive service delivery programs in humanitarian settings, strengthen supply chains and improve commodity security, improve availability of and access to LARCs and EC, address barriers for adolescents and other marginalized populations, and to strengthen coordination across the humanitarian development nexus, particularly in preparedness and recovery phases. Ultimately, it is clear that contraceptive service delivery is underway in humanitarian settings, including a range of methods. As we continue our efforts to ensure that contraception is available to all who need and want it, no matter where they live, we look forward to leveraging the strategic planning guide for family planning in humanitarian settings. Thank you.
Thank you, Lily. It's really exciting to see research and learning documented and shared with our community across the nexus, folks who are on the call today. So we really appreciate your presentation. Next, it's my honor to introduce to you Elizabeth Sadavatar and Risnawati Arianti, and these are our colleagues from UNFPA Indonesia. So ladies, the floor is yours. Thank you.
Thank you, Beth. Good morning, everyone, and good evening, everyone. So we from Indonesia, from UNFPA Indonesia, would like to share with you lessons learned from our humanitarian interventions, preparedness, and response, especially on the family planning services in crisis situation in Indonesia. Slide. So Indonesia is one of the prone countries in region, Asia Pacific regions, with the total populations more than 270 million. And 97% out of the total population are living in disaster-prone area. And maybe you're aware that one of the biggest tsunami in Indian Oceans occurred in 2004, which is in Aceh, and the last 2 years is a liquefaction in Central Sulawesi. So in 2019, more than 9,000 natural disasters occurred that affected 5.3 million people and displaced. And in 2020, up to 31st of May, more than 1,600 natural disasters with 500,000 people affected and displaced. You can see the family planning indicators in the screen. Slide. So preparedness is most of the critical part and very important. The adaptation of the international minimum initial service packages have been facilitated by UNFPA since 2003. And with the advocacy more than 8 years, government led this process all, and government as well supporting provide the supporting policies. So under the leadership of Ministry of Health, Indonesia developed and endorsed the National Minimum Initial Service Guideline and Operational Guideline, and as well the Logistic MISP Guideline, which is part of the logistic part is family planning, logistic and contraceptive supplies inside. So the other important part during preparedness is capacity development for reproductive health subclusters and integration of the MISP itself into the midwifery local curricula. Ministry of Health put the effort to coordinate and put efforts to play the role to coordinate the activation of the clusters and with the support from UNFPA. Another side, since 2017, UNFPA also supported the Ministry of Women Empowerment and Child Protection also to activate the GBV coordination's role. And the other preparedness that we prepared is deployment mechanism. So by having good advocacy, and it will be enabled government-led and produce the supporting policies and by government. Slide, please. So as I introduced the MISP guideline, there are 6 objectives, and then one additional objective that also highlighted in HIP strategic document is number 6, the prevention of unintended pregnancies through family planning services. So during UNFPA Indonesia responses to 2018 and 2019, we were able to implement those objectives in the Central Sulawesi and NTB earthquake. Slide. The objective 1 is the activation of the reproductive health subclusters. This is the good lessons learned that we learned a lot from the leadership of the government. The RH coordinator assigned in both disasters, and focal points also assigned, including focal points for the family planning, continuation of family planning services in Central Sulawesi and NTB earthquake. And we did the deployment of the reproductive health team response and provided direct assistance and response for initial 1 month. And we saw whether we can shifting the coordination role to the province within 1 month, 2 months, or 3 months. But the technical assistance for the continuation of the subcluster coordination still managed by Ministry of Health and also supported by UNFPA. To ensure that the reproductive health will be functioned well in the affected districts until we can give them shifting coordinations role 100%. One of the critical part is that the data reporting and humanitarian situation. So we also supported the data and information management during the responses under National Disaster Management Authority. So during this activation of reproductive health subclusters, we initially, during the response, we start the advocacy for sustainability of the reproductive health subclusters in affected area. Slide, please. The objective 2 is prevention and management of GBV. The cases of GBV heightened increasingly during the humanitarian situation. So by having the subclusters and then having the focal point to lead the subclusters that established and functioned the woman-friendly space in the Central Sulawesi and NTB. So we introduced the sexual reproductive health and GBV linkages services through these woman-friendly spaces, reproductive health and family planning education, and provision of psychosocial support. So community-based referral mechanism is one of our good practices in the Central Sulawesi, where the GBV referral mechanism and management are community-based, led by the women-led NGOs. And then the other important part is we also did the care for the care providers, which is women volunteers who are working in the women-friendly spaces. So through the capacity development, we empowered them because most of the care providers are also GBV survivors during the Central Sulawesi humanitarian response. Slide, please. The objective 3 is prevention of STIs, including HIV transmissions. The most difficult part is to identify the partners in the affected area who are working in the most vulnerable target group. But during the NTB and Central Sulawesi, partners identified, and then the identification of data also able to be managed. So the continuation of ERV provisions provided both in NTB and Central Sulawesi. Outreach services led by the local NGOs, and through the community engagement, we are able to mobilize the services directly to the community. The other part that we also have a midwife trained on the universal precautions and some clinical trainings, how to prevent the transmission of the STIs, including HIV. Slide, please. The objective 4 is the adolescents, inclusions, and youth engagements. So in the national guideline, we government and us provided the one objective for the adolescents, inclusion, and youth engagement. This really powerful results that we've done in Central Sulawesi because having space for adolescents and youth, and it creates and resulted a powerful result for advocacy and engagement by having them engage and the minimum participation through facilitation, parliamentarian meetings as resource persons, has introduced action plans that really youth friendly, and then a policy for the rehabilitation. So we able to establish the youth forum that linkage with the government, and it's function until now, but UNFPA is not there anymore. So SRS and GBV education, especially to how to educate the teenage and then adolescents and youth to avoid unintended pregnancies, and peer counselors and SRS and services provided through this program in Central Sulawesi. Next slide, please. The next objective, which is 5, the prevention of the preventable maternal death and neonatal morbidity and mortality. During the process, we ensured that the availability of the sexual reproductive health services to 24 hours and 7 days through reproductive health plans that are closely accessible by the IDPs, internally displaced persons, and then through the midwives deployment program, we did the 3 until 6 months interventions. That depends on the disasters. In NTB, it's only 3 months, but in Central Sulawesi, because quite huge, we provide it until 6 months, and the rehabilitation continue for 1 year. So capacity strengthened for the affected midwife, introduced the clinical management of training, and then also as well the minimum in sexual reproductive transmission services, and also the universal precautions. Care for providers is really important during our lessons learned because they need the psychosocial support as well. So by having midwife deployed within 3 to 6 months, that enable the midwives, the affected midwife, to be strengthened and to enable them to be function again after the disaster in Central Sulawesi. So the family planning services continue in reproductive health plans, but they also do the outreach and through the mobile services. Partnership is very crucial. Under government-led, there are some NGOs also working, private sectors, to ensure that will be referral mechanism for maternal and neonatal services. Next slide. The prevention of unintended pregnancy, this has become our priority during the NTB earthquake responses. The high demand of the family planning is very high, and then that's also occurred in Central Sulawesi. So there are 2 types of the family planning services that provided both the disasters. One through the reproductive health plans, and then the other what outreach services or mobile clinics led by the national planning agencies, who closely works with us as well. And then by having education and community engagement through women-friendly space, the number of the services is increased during the response. We having difficulties through the contraceptives availability during that time in Central Sulawesi, but by having a good partnership with the NGOs, clinics, and private sectors, so we were able to mobilize some contraceptives, and there are some lessons learned later on that will be shared to you. Next slide. So this is one of the share from the midwives that she is really happy to doing their jobs because she's living in the community, in the IDPs, and then provided services directly to the community. Next slide. Last but not least, to ensure the integration of humanitarian response into the comprehensive reproductive health services is really crucial. So one thing that we remember and also we share during our intervention, don't create new mechanisms during humanitarian response, but we need to strengthen the existing or government mechanism. So put government-led in all efforts and then strengthen their capacity in local, and then so it will create a localization, strengthen the ownership, as well how to link the non-government and to be part of the clusters coordination, and to ensure the sustainability and monitoring as well. So the integration to the essential reproductive health services is really crucial. This also enables the community engagement by having translating the women's girls' voices into the cluster coordinations regularly. So during humanitarian response, it's a good opportunity as well to improve the system in the affected area. I hand it over to Ima.
Thank you, Ibeth. A lesson learned from humanitarian responses into natural disaster in 2018 and 2019 in Central Sulawesi and NTB highlighted the importance of having the following components in place to ensure continuity of family planning services in humanitarian setting, some of which were missing or needed strengthening during the response phase. It is important to have a coordination mechanism led by the government. Therefore, functioning family planning humanitarian working group with a clear terms of reference is crucial. We also need to have rapid assessment on contraceptive availability and costing of contraceptive need and supply chain management. It is important to have a special contraceptive distribution mechanism in place as an alternative to address the need of the situation in the affected areas. In NTB, for example, the provincial offices and health system were not affected, so they could still functioning in providing response and services. While in Central Sulawesi, the provincial offices were very much affected. Therefore, distribution of commodities should be backed up by the central. It is also important to engage non-traditional partners, the grassroots organization, the private sector, to join the response, including in ensuring availability of contraceptive commodities. Ensuring availability of data, information, community engagement are also as important. Next slide, please. Having understood the need to have a systematic approach in ensuring continuity of family planning services and commodity during the crisis, the government, in this case, the National Population and Family Planning Agency, initiated development of a guideline on contraceptive services in crisis situation facilitated by UNFPA Indonesia. The guideline development was supported also by Global FP 2020 through the Rapid Response Mechanism. This slide shows that the guideline covers the following activity that needs to be implemented to ensure continuity of family planning services during the preparedness phase, the response phase in a crisis, and during rehabilitation phase where the service should be gradually integrated to existing health system. The guideline was originally aimed to address crises due to natural disaster, but when COVID-19 pandemic started in March, it brought up a different complexity and requiring a different approach in delivering response in addressing the crisis. So it was decided to add a chapter on the non-natural disaster crisis due to communicable disease outbreak, which reference to COVID-19 pandemic. In addition to the overall guideline, we are also in the process of developing a technical operational guideline completed with a cheat sheet for an easy reference for the providers and terms of reference on the family planning humanitarian working group to be included in the guideline. Next, please. Now about the COVID impact in Indonesia. The impact of COVID-19 is still being assessed and several assessments are on the way. However, there have been anecdotal reports that around 900 private practicing midwives closed their practice due to lack of personal protection equipment. Of course, this is a major concern as they are the main providers for maternal and family planning services in Indonesia, and we are working to address this issue. There have also been reports on decreasing maternal health service coverage as well as family planning services with a drop of 30 to 40% in the month of March compared to February this year for all contraceptive methods, and we are still following the situation in the month of April and May. Next, please. The current COVID-19 response in reproductive health is led by the Ministry of Health and the National Family Planning Agency, includes maintaining high quality and standardized family planning services as part of reproductive health services with precautions to infection. Ministry of Health have developed standards for reproductive health services with reference to global and regional guidelines, as well as from the professional organization. The main guide is limiting physical visit to the health facilities and prioritizing emergency and complicated cases. They are also done through prior appointment to reduce waiting time. Other non-urgent visits can be delayed. For this purpose, implementation of remote consultation or telehealth is very crucial, using various platforms, including online, mobile phone, or landline. Providing adequate supply of contraceptive commodities and applying alternative options during the pandemic is also the priority of the government. The National Family Planning Agency has introduced an alternative distribution mode by engaging family planning field workers to distribute pills and condoms to the user under the supervision of health providers. And of course, an important issue also providing personal protection equipment for the health providers, including the practicing midwife. Next slide, please. UNFPA Indonesia has been supported the government of Indonesia and other partners in response to COVID-19 pandemic. We are conducting assessment on impact of COVID-19 on reproductive health services in Indonesia in collaboration with the various government agencies. Data collection are currently underway. We facilitated the development of the guideline that I explained before. And we supported Indonesian Midwife Association for continuity of services by providing personal protection equipment for midwife in the most affected area and providing dignity kits for gender-based violence survivor, pregnant and post-delivery women and their newborn. Next slide, please. Finally, I want to end this presentation by bringing up a quote from Dr. Natalia Kanem, UNFPA Executive Director, to remind us all that women's reproductive health and rights must be safeguarded at all costs, the service must continue, the supply must be delivered, and the vulnerable must be protected and supported. Thank you.
Thank you very much, Elizabeth and Risnawati. It's a great experience to hear from what you've learned in Indonesia and in particular what's happening now under the COVID crisis. Your experiences in the past, and it's always unfortunate to have to work through a crisis, but demonstrating the ability of the system and the people within it to learn and to respond more effectively based on that learning going forward, I think is inspiring to all of us. So thank you for sharing your presentation. I want to remind everyone on the line that you can submit questions through the question panel. So please remember to ask your questions as we're going along. We can collect them so that when we get to the Q&A, we are ready to go. So next, I'd like to introduce Jamil Zamir, who is with IPPF ESOR. So Jamil, over to you.
Thank you, Beth, and thank you for this. Thank you for the opportunity to share the work of IPPF. So let me begin my presentation with the picture from our member association in China on receiving the consignment of personal protective equipment at the very early stage. And now the China Family Planning Association is now donating large quantities of PPE to other MAs globally. So we are locally owned and globally connected. Slide, please. So IPPF is a leading service provider and advocate for sexual and reproductive health and rights. ESOR is one of the IPPF 6 regional offices, which is based in Kuala Lumpur, Malaysia, and has a sub-regional office in Fiji. We work with 25 member associations and 3 collaborative partners in the region. We have IPPF Humanitarian Hub in Bangkok. So as we look at most of the countries in this region, shows that there is a flattening the curve of coronavirus infection as the number of cases continue to remain low in our region, except countries such as Indonesia and Philippines. However, looking at the informed epidemic risk index and the informed risk index, what it really tells us is that half of the countries in the Southeast Asia and the Pacific are vulnerable to the humanitarian crisis. Slide, please. So for IPPF, one of the biggest initiatives was to really bring a nexus and integration of humanitarian work with the development intervention. And in 2018, IPPF came up with the humanitarian strategy, and the entire focus was to apply a humanitarian lens to every process we undertake. And it calls for a cultural shift within IPPF primarily to see that federations' agility to quickly respond with quality services, make adequate investments in the systems, and advance the strategic partnership. And over a period of time, there has been investment in a number of areas, as you could see, from policy space to technical and clinical areas to operational areas. And one of the important points, as we see on the right top about the humanitarian spectrum, is that it's not just important to really have an effective response, but also to ensure that there's a smooth transition from response to recovery, to mitigation and preparedness, and we continue to invest on that. So that has been the focus, and over a period of time, as things have moved, IPPF has developed the emergency response activation system, surge capacity roster, and has undertaken a number of responses. Slide, please. So as we look at the services statistics from 2019, the ECO region has provided 20.2 million services through diverse service delivery outlets, and 32% of these total services are contraceptive services. Around 10% of the SRS services are delivered in humanitarian settings. And if we go by the breakup of the methods, about 74% within the contraceptive services are short-acting methods, and 22% are long-acting contraceptive methods. Next, please. So in early March, IPPF constituted a task force for a coordinated response to COVID-19 and has undertaken a survey in March and then later on in May. And as you can see from this table, 25% of the static clinics were closed in March, and over a period of time, as we saw it in May, the member associations have reported that those are operational due to a number of interventions that I will talk about. Same way with mobile clinics, about around 20% of the member associations have reported the closure of the mobile units. And the associated facility where we work with the public and private sector and the CBDs, which are not affected as we continue to provide supplies to them. And so if you look at the scale down the availability of FP services, about 32% of the member associations reported the scale down, and it remains pretty same till May. But if I just look at the data set from the scale down of the availability of SRS services, it was around 76% in March, which has then improved to 48% in May. So basically trying to communicate the message that there has been a scale down, either decrease by hours, by sites, and the number of service providers. However, family planning being a core area of IPPF remain quite consistent, and we are trying to ensure that we gradually expand to other range of services as well. So the range of interventions that have taken place as part of the response was that IPPF has provided the C19 measures in terms of infection prevention and control. So the triage and early detection, syndromic screening, hand hygiene, and so on, and PP. And there are digital health interventions using the telemedicine online platforms and range of including the home delivery of contraceptives, and also using the postal services. And during this process, there has been mobilization of resources to ensure commodity security and continuity of services. Next, please. So coming back to the experience during the response, what we have seen is that the role of localization is critical in humanitarian emergency. IPPF work with our with MAs, member associations, to build the partners' capacity and skills, and with the community leaders, and particularly women and young people. And we have seen that it has been a huge resource in terms of organizing and delivering of the services. Coming to the intersectoral coordination, it has this is one area which requires further investment and focus, as we see that it is so critical that the effectiveness of the MISP is strongly dependent on this. And one of the examples that I would like to give is that client come up with the multiple needs, health needs, and which includes the general health. And one of the challenges is to ensure focus on MISP services, on family planning services. And so we try to come up with some innovative strategies to make sure that we have a higher proportion of MISP services while also providing other set of services. And so this intersectoral coordination becomes extremely critical as certain services are being shared as part of MISP services. Then coming to the contraceptive distribution, particularly with reference to access to young people, and how such depots have been created even in these spaces which are friendly to young people so that they can access. Besides that, we found that the first line support is very, very important along with the intervention. And then coming to the quality of care, and within the quality of care, we have seen that there are staff challenges and how those are being addressed. There's a constant need for refurbishing of the facilities, monitoring of the quality of care that we have been using different checklists and tools, follow-ups of the client, and referral mechanisms. Then to the managing the supplies, and particularly I would like to emphasize here that localization is extremely critical also within the supplies framework, as the local purchase really is solution. Many times we have seen there has been a delay in the supplies when it's coming from outside. And lastly, within the work of advocacy, what we have seen is that member associations in this region, they are part of the national FP20 teams and are advocating for FP in humanitarian settings. Slide, please. Now, these are some of the pictures from the tropical cyclone Harold category 5, and you could see that how the COVID measures are put in place, reaching out even to the disabled population, and providing family planning services. In this, we have also got the clients who are having the expiry implants, and those are being removed. So a broad range of family planning, long-acting reversible contraceptives were provided along with the short-acting methods. Next, please. Now, I would like to briefly touch upon a very important area, which is men's contraceptive use, and we see that it has been not been appropriately focused, and it's an untapped potential. We continue to have a very small share of the overall uptake of contraceptives. There's a need for a positive approach to male engagement, not just reaching out to men with only condoms and vasectomy services, but actually expanding their role for their need for other SRS services and for advocacy. So this is a tool which really provides a lot of approaches and the quality standards for the provision of SRS services to boys and men. Slide, please. So some of the key messages that emerged through our intervention is that, just want to reiterate that family planning is a life-saving humanitarian intervention. There's a strong demand for family planning services in humanitarian settings. There's a need to integrate family planning at each stages of humanitarian interventions. We really have LARC now as part of Objective 5 of MISP, and how we continue to really promote as part of contraceptive choices. There is a need to really invest on the readiness and ensure availability of the staff, and building into the health and emergency management plans. And lastly, the flexible funding for FP and humanitarian. Slide, please. So these are some of the pictures from our member associations, how they have organized their service delivery due to COVID. Thank you.
Thank you very much, Jamil. It's an excellent presentation, and I particularly appreciated the last slide that you had on lessons learned, because one of the things I think that many people might be surprised about is both the opportunity to work with populations who've been displaced, to potentially introduce them to new methods of contraception, to expand counseling and learning about what contraception is and what contraceptive choice can be, and that we can be reaching out to men and to male partners and to communities as well, to break down some of those barriers for adolescents that persist in all contexts around the world. So the learning that IPPF has gained over the recent years, and your willingness to share that with all of us, is deeply appreciated. We saw as well through the UNFPA presentation with Elizabeth and Risnawati that supply chains and localization remain critical, because people who move with communities of displacement are also those who can be frontline service providers and are the people that everyone trusts within their community. So we should be both empowering them to continue as professionals to provide these kinds of services, and then ensuring that we maintain those supply chains so that we can expand access as well for everyone. So I want to encourage folks to submit questions. I don't see any yet at the moment. And I think it's probably because there's a technical glitch on my end and I can't open the question box. So I'm going to ask Ados at IBP to step in and help maybe to ask some of the questions that have been submitted, since they're not visible to me at the moment. So Ados,
Okay.
can you step in for us, please?
Yeah, my pleasure, Beth, and apologies for that. We have a question for UNFPA, the Indonesia team. What were the key features you needed to consider to include COVID-19 and challenges? Ibeth or Ima?
Yeah, this is Ima. I think what we have from our experience, the need to integrate COVID-19's response is something that come immediately when we enter the COVID-19 pandemic in Indonesia. The challenge that we see is because the way we are working is very much different. This is a kind of different crisis that we are facing, and none of us is really have a full understanding, and we are still learning how is the best way to do the response. So what we are facing, we don't have very much challenges, but more in terms of getting new information, learning from different countries, what is the best way to integrate to solve the problem and provide services. And also, as we are entering the new normal, I think we are also will face various other situations that we never faced before. And this is also need a kind of sharing lesson learned from different countries, learning from the best practices, so we can adopt our guidelines. And what we are seeing right now, the guidelines, the standard operational procedure is also keep changing to the new evidence. So it is very different than the other situation, and we need really a kind of flexibility in addressing this situation.
Thank you. And a follow-up question also for your team in Indonesia. Could you please talk briefly on how are strengthening GBV referral pathways and to ensure victims, survivors receive safe GBV care services?
Thank you, Ados. This is Ibeth. The way that we address the GBV services in humanitarian situation of the affected area is by strengthening the community-based referral mechanism, where we equipped the capacity for the women-led NGOs who were already in the area and then trusted by the community and women itself. So they have put trust on the local institution that are available in that area. And for the referral mechanism, there are the things that we provided during humanitarian. What is the referral to the health? The second, what the referral for the psychosocial support. There are 4 stages for the referral, but these 2 really important to ensure that the survivor will be not pregnant or survivor will be avoiding from the prevention of HIV and sexual transmission. So referring them by before 72 hours is really important and crucial. So by having the focal points and then trained midwife of clinical management of training, it will create a network and then how to refer them appropriately in the appropriate time. Thank you, Ados.
Thank you, Beth. And this is a question for Jamil. Jamil, this is from a colleague who's asking for a little bit more information on the telemedicine interventions that some of the MAs of IPPF are providing.
So, there are range of diverse interventions within the telemedicine. Like 8 of the member associations in our region are providing, and it ranges from telecounseling to teleconsultations to follow-ups. There is a HelloDoc app in Indonesia to prescribe clients with drugs, and also teleappointments. So, but it's very context specific, and so we recently have a webinar on this, and the more information is available on this, and there are a couple of other guidelines that have come through. So, but definitely what we are seeing is that that's the way forward to modernize the service delivery. And we can share more of the case studies and the other guidelines on this.
Great. Thank you, Jamil. The last question, I'm being conscious of the time. We have 5 minutes before we close. It's how can we ensure long-acting, non-reversible contraceptive methods and permanent method services are continuously provided during the crisis period? And I would like to ask this question to each of the panelists. So perhaps we could start with Jamil and then move to the UNFPA team and then Lily.
So for long-acting contraceptives, particularly with reference to the IUDs and implants, what we have seen is that it's part of the contraceptive choices. So one is the counseling, more information about the method. There are also challenges sometimes with the supplies with the implants. And so it's a combination of a range of things along with quality of care, which is extremely critical in terms of IUDs and implants. And what we have seen is that if you ensure quality, if you have adequate supplies, if you have service providers who are trained on infection prevention, insertions, and so on. It works very well along with the counseling. So there is an uptake, and generally people also make a shift from IUDs to implants.
From Indonesia, I think there has been policy of the government to switch to long-acting reversible method and long-term method, which has been quite successful in the past. With the COVID-19 pandemic, there has been problem with the restriction of movement, and the readiness of the facilities in preparing and receiving the clients. So we've seen in the past months there has been reduction in use of long-term method. However, as we grow and the facility are more ready with providing with PPEs, and they are starting to provide more long-term method. So I'm sure when as we go through the transmission and we go through the new normal, this situation is getting better. And what we've seen before in the couple of months, switching to the short-term method can be also generally going back to long-term method. Of course, this is regarding and considering the options that the clients really want. Thank you.
Is that to Otto? Should I go ahead?
Go ahead, Lily.
Great. Just wanted to make sure I didn't cut anyone off inadvertently. You know, I think first to echo agreement with what my fellow presenters have said, to refer back to the project that I presented on and what we have in terms of research around supporting access to, availability of, and uptake of long-acting methods. We did see, as has been noted, that there were particular barriers and misconceptions around LARCs, but the literature review really did document that there is an evidence base for programs that can improve uptake of long-acting methods. Those multi-pronged programs that we referred to that were designed to address provider capacity, method mix, supply chain strengthening and monitoring and evaluation, all, or pretty much all of those consistently demonstrated improved uptake of long-acting methods. I think we would also add that with that being said, every context is unique. So there's not necessarily one particular action or activity that will result in success across the board. And the implementation of different programming and strategies should be really tailored to individual contexts, but that we do have good information about what works and about what can be a good starting place to address that in different humanitarian contexts.
Great. Thank you so much to all of you, and thank you, Otto, for stepping in to help with the Q&A. I want to thank all of our presenters today, Lily Jacoby, Elizabeth Sudabatar, Riznawati Arianti, and Jamil Zamir, and for the partnership with your organizations, Women's Refugee Commission, UNFPA, and IPPF. Working together with High Impact Practices Team and IBP is a really powerful consortium for learning and sharing information. We want to thank you as well for your organizations for being on the front line of service delivery and helping all of us to learn and to shape better programs over time. We want to thank all of the participants who called in today and remind you that we will be launching the SRHR Toolkit, Ready to Save Lives, at the end of this month, likely in early July. And we see today's discussion and presentations as starting this sort of kickoff of talking about preparedness, particularly within the context of this pandemic. So when we launched the toolkit, we're bringing the community to that information with greater learning. So thank you to everybody for making time today to share your presentations. Don't forget where you can get more information at these websites. And please do reach out to all of us if you have questions or if colleagues would like to learn more about preparedness in the coming weeks and months. We also want to wish you all of the best, and that you all stay healthy and safe during this pandemic. And for those who are in the US, to stand in solidarity with the Black community as we face considerable upheaval in dealing with some of the social issues that we're facing here that have gone so long unaddressed. So thank you to all of you for your partnership, and we look forward to working with you going forward as well. So thank you, stay safe, and I hope that we have a chance to talk again soon. Goodbye.